Welcome to this presentation, The Weakest Link, Transitions of Care for International Patients. Let's start with a simple question. When does the patient journey end? Is it when the patient is discharged from hospital? When the bill is paid? When the testimonial is received? When the patient arrives back home? The answer to this question depends on who you ask. If I were there with you today and I went around the room to ask each one of you, when does the patient journey end? I would have a wide variety of answers to choose from. So why don't we all have the same answer? I believe it's because there are no widely accepted, scientifically derived international standards governing transitions of care that ensure a successful conclusion to the patient journey. What does the term transitions of care mean? The term refers to the coordination and continuity of healthcare for patients during movement from one healthcare setting to another or when returning to the patient's home. Transitions of care are set out in the discharge plan. No widely accepted international standards for discharge planning exist, which creates an extra risk for medical travelers. In medical travel, it may be unclear as to who is responsible for creating, organizing, communicating, and ensuring compliance with the discharge plan that governs the transitions of care. So what happens when there's a failure to deliver coordinated care at and following discharge? The lack of careful planning of transitions of care lead to terrible situations like this: the death of 22 Brits after going to Turkey for surgery. And this situation is not just prevalent in Turkey, it happens in other destinations, such as 90 Americans dying after surgery in the Dominican Republic. Behind these awful headlines is research that shows that poor discharge planning and gaps in the transitions of care contributed to these deaths. Almost every one of the 22 Brits and 90 Americans' deaths could have been avoided by a comprehensive discharge plan. Failure to deliver coordinated care contributed to the deaths of these patients. How do we know what should be done to improve transitions of care? Research provides the answer. Research based on Project RED, Re-Engineered Discharges, confirms that gaps in transitions of care result in inappropriate hospital readmissions. And in the United States, these readmissions are heavily fined. Unnecessary surgeries, unhappy patients, and in many destinations, including the United States, lawsuits for malpractice. Unnecessary deaths, as we've seen in these tragic headlines. Damage to brand reputation and financial loss. Let me share a few words about Project RED. In 2009, a team led by principal investigator Dr. Brian Jack published the results of a large randomized trial to measure the impact of improving the patient discharge process to reduce hospital readmissions, increase patient satisfaction, and improve the bottom line. Included as one of the articles in the 2012 book, 50 Studies Every Doctor Should Know, the revolutionary article, A Re-Engineered Hospital Discharge Program to Decrease Rehospitalization, has been awarded the prestigious Drucker Award, inspired thousands of researchers around the world, and spawned almost 2,000 peer-reviewed articles. It sets the 13 best-in-class international standards for transitions of care. This research article is available on the Project Red Solutions website for you to download. So let me review what we call the Project Red's Lucky 13 Principles of Excellence in Transitions of Care. The first group of Lucky 13 focus on systems and process-based interventions. So first and foremost, provide a written after-hospital care plan that the patient understands. All too often, patients are either given nothing or handed inches worth of paper documents written primarily in medicalese that they have no hope of reading, understanding, or complying with. Of course, medication reconciliation and education is important. Medications that the patient was taking before receiving medical care, receiving during the stay in hospital or clinic, and post-discharge should all be harmonized, and the patient should be educated about what to take, what to stop taking, and other important information about pharmaceutical compliance. Create a follow-up plan for outstanding labs and tests. Most patients require some sort of follow-up treatment that may include going for additional laboratory tests, other types of tests. And then coordinate with the patient follow-up appointments that the patient can keep. Don't leave it up to the patient or some other, a caregiver or some other unknown party to arrange these follow-up appointments. Help to organize post-discharge services and equipment, such as wheelchairs and other medical devices that might be necessary. Make sure that the discharge plan has been reconciled with national and international guidelines, such as those set out here in Project Red. And provide meaningful telephone reinforcement 2 days after discharge. And by meaningful telephone reinforcement is meant actually contact and speak with the patient no more than 48 hours after discharge. The second group of principles deal more with interpersonal, educational, or behavior-based interventions. So it's very important before the patient is discharged to assess their understanding of what is being asked of them in terms of follow-up appointments, further communication, medications, and so on. And the way to confirm understanding is to engage in what's called the teach-back method of information giving, which means I explain something to you and I ask you to repeat to me what I just said. That gives you an opportunity to evaluate whether the person understands what is needed and, if necessary, to engage in further conversation or education. Of course, determine the need for and obtain language assistance. This may involve interpreters, translators, and so on, to make sure that the information is being understood by the patient. Provide education about the diagnosis. So whatever the diagnosis is, once the patient is ready to be discharged, make sure they understand what procedures they've had and what their prognosis is for the future. Throughout this process, it's important to involve the caregiver in just discharge planning, because as we know, it's often family members or friends who will help the patient return to better health. And then finally, Lucky 13, explain common problems and what to do if problems arise. So in reading the research around the deaths of the Turkish, of the Brits and the Americans, it turns out that there was very poor or no education about what to do regarding common problems. So for example, infection of a surgical site, what does it look like? How will the patient know? And then what should they do if they believe that an infection has set in? And of course, it is the responsibility of the hospital or clinic or another professional to be responsible to help the patient through what might be a problem before it leads to something more serious. So in summary about Project RED, ensure that there's a comprehensive discharge plan that follows the 13 principles set out in the research related to Project RED as an essential ingredient to define and deliver a successful end to the patient journey. If we all dedicate ourselves to deliver an excellent, complete patient journey, the world of medical travel will be a safer place for patients. We can say goodbye to terrible headlines and hello to excellence. So I invite you to visit the Project RED Solutions website to download the list of the Lucky 13 research articles and the Project RED Toolkit, as well as other information about transitions of care. Feel free to contact me if you have any questions about this presentation, and thank you very much for your time.